Let's walk through the neurodiagnostic tests you're going to see in both the classroom and the real world, especially when you've got a patient like Earl who's showing signs of neurological decline. These tests are how we gather the evidence. And as nurses, we're not just bystanders. We're the ones preparing the patient, protecting them, and picking up on anything that might go wrong before, during, or after the test. CT scan, with and without contrast. We use CT scans when we need fast answers. It helps us spot bleeding, tumors, infarcts, hydrocephalus, or even early signs of atrophy. Think of it as a topographic map of the brain. When contrast is involved, we get better detail, but also more responsibility. First thing, check kidney function. If the kidneys can't clear the contrast dye, it builds up and causes trouble. So always look at BUN and creatinine. Next, ask about allergies. Iodine or shellfish allergies? Red flag. You'll need to notify the provider, and in some cases, pre-medicate with steroids or antihistamines. If the scan's scheduled with contrast, your patient should be NPO for at least 4 hours, and you'll need to start a peripheral IV. Let the patient know they might feel a warm, flushed sensation when the dye goes in. That's normal. But hives, trouble breathing, or a metallic taste? That's not. Monitor closely during and after for any allergic reactions. Once the scan's over, encourage fluids to flush that dye out of the kidneys and reduce the risk of contrast-induced nephropathy. And remember, patients need to lie completely still. Even a tiny movement can blur the image. MRI, magnetic resonance imaging. Now, MRI is the queen of soft tissue imaging. We use it to look at tumors, spinal cord issues, MS lesions, and strokes. But unlike a CT, MRI uses magnets, not radiation. And magnets don't play well with metal. Before you even let the patient near that machine, do a thorough metal screening. Pacemakers, aneurysm clips, cochlear implants, or even transdermal patches with foil backing can be dangerous. All jewelry has to go. Rings, earrings, credit cards, you name it. You might even find old tattoos with metallic ink or retained shrapnel, especially in veterans. Double check. MRIs are loud and long, 30 to 60 minutes, sometimes more. If the patient is claustrophobic, talk to the provider about sedation. And if they're sedated, you must monitor vitals, oxygenation, and consciousness the entire time. Reassure them there's a microphone, they can communicate if needed, and yes, it's going to sound like they're in a drum line, but it's temporary. SPECT Scan, Single Photon Emission CT. This scan checks cerebral blood flow and perfusion, especially helpful for stroke, tumors, or seizure disorders. It uses a radiopharmaceutical tracer, which means you'll need to ask about allergies and pregnancy or breastfeeding status, because this test is contraindicated in pregnant or lactating patients. The radiation is minimal, and you should reassure the patient that it's safe and non-invasive. The tracer is injected, and then the patient needs to stay very still during the scan to get accurate images. Reactions to the tracer are rare, but not impossible. So monitor the patient, especially after injection. Sharp cerebral angiography. This one is more invasive, but gives us the most precise look at cerebral arteries. We use it to visualize aneurysms, AV malformations, stenosis, or blockages. Your prep begins early. Check renal labs, make sure the patient is NPO for 4 to 6 hours, and mark the peripheral pulses. That way you can compare before and after. The access site is usually the femoral or radial artery. Clip and cleanse the site and educate the patient. They'll feel a warmth or metallic taste as the contrast flows through. That's expected. What's not expected? Neurologic changes, limb numbness, or a growing hematoma at the site. You'll be watching for signs of embolism, vessel dissection, or bleeding. If they went through the groin, the leg needs to stay straight and flat for 4 to 6 hours. If they went through the wrist, you'll apply a pressure band. Elevate the wrist, and keep an eye out for swelling or compromised circulation. Carotid and transcranial Doppler. These are non-invasive tests that use ultrasound to check blood flow in the neck and brain arteries. No IVs, no radiation, just gel and a wand. Explain to the patient that this will be done bedside, usually takes less than an hour, and they'll need to lie quietly and stay still. Easy, right? But don't skip the education. Patients who try to chat during the scan can mess up the readings. EEG, electroencephalogram. This test shows us the brain's electrical activity. It's key for evaluating seizures, coma states, or confirming brain death. Prep starts the night before. Tell your patient, no caffeine or stimulants, and follow specific medication instructions from the provider. During the test, electrodes are applied to the scalp with paste or gel. You might use strobe lights or ask the patient to hyperventilate to provoke abnormal brainwave activity. So be prepared for seizures. You must have precautions in place. Quiet room, dim lights, minimal stimulation. The patient should not move, talk, or open their eyes. And yes, you'll be right there in case anything happens. EMG and nerve conduction studies. When we want to know whether the issue is in the muscle or the nerve, we use these tests. EMG involves inserting a needle into the muscle, while nerve conduction tests use electrical stimulation to measure speed and strength of signal. Tell your patient the needles will feel like IM injections, and there may be some brief soreness afterward. The electric shocks aren't painful, but they're odd, so give a heads up. Stay with your patient for reassurance. Anxiety and muscle tension can affect the results, so calm coaching goes a long way. The Evoked potential studies. These measure how fast and accurately stimuli like lights, clicks, or skin taps reach the brain. There are 3 types: visual, flashing lights, auditory, clicking sounds, somatosensory, gentle electrical skin stimulation. We use this to evaluate MS, spinal cord injuries, or during surgery to protect neural pathways. Your job? Keep the room quiet, lights dimmed, and explain that any movement ruins the data. Lumbar puncture, spinal tap. This test collects cerebrospinal fluid, CSF, for analysis. It can help diagnose meningitis, hemorrhage, MS, cancer, or pressure disorders, but it comes with risks. Before the procedure, always check recent CT or MRI results. If the patient has increased ICP or a mass, a lumbar puncture could trigger brain herniation. Don't skip this step. Help the patient into a side-lying fetal position or seated, leaning forward. Reinforce the need to remain still while the provider inserts the needle. Afterward, you'll monitor for headache that worsens when sitting up, back or neck pain, fever, neurologic changes, urinary retention. Keep the patient flat in bed for 4 to 6 hours to prevent that post-LP headache. Push fluids, and yes, caffeine helps. And get those CSF samples to the lab immediately. Any delay can skew results. Final takeaways. Each of these tests gives us a different window into what's going on inside the nervous system. But your role as the nurse is just as critical as the test itself. From making sure the kidneys can handle contrast, to stopping a seizure before it starts, to keeping a lumbar puncture patient flat enough to avoid a headache. You are the difference between a smooth diagnostic process and a dangerous one. Know the test, know the prep, know what could go wrong and how to prevent it. And always remember, the brain doesn't give second chances. We have to get it right the first time.